Hello everyone. Today in our series of Dr. Keval interviews, we are honored to have with us Professor Dr. K. Srinath Reddy. Dr. Reddy is presently the President of Public Health Foundation of India and formerly headed the Department of Cardiology at All India Institute of Medical Sciences, AIIMS, New Delhi. He has served on many WHO expert panels and has been the President of the World Heart Federation 2013 to 2014. He was appointed as the first Bernard Lown Visiting Professor of Cardiovascular Health at the Harvard School of Public Health in 2009. He is also an adjunct professor of the Lawrence School of Public Health, Emory University, and honorary professor of medicine at the University of Sydney. Today he'll discuss with us about the cardiovascular health of individuals across lifespan. Thank you, Dr. Reddy, for joining us today. So can you please elaborate on your experience and learnings from the INTERSALT and INTERHEART global studies for blood pressure and MI risk factors control?
Well, one of the reasons why both INTERHEART and INTERSALT were conducted, INTERSALT of course was earlier, is that you need to study multiple populations to study the impact of risk factors on health outcomes in a large enough sample which provides a wide range of exposure to risk factors. If you study one single population, even though there would be some variation within that population, the range is still restricted. So when we were doing INTERSALT, the issue was what is the impact of dietary sodium and potassium consumption on blood pressure. Now, if you take a population only in Delhi or only in Ladakh, you are likely to get some variation. But if you take populations across the world, the range would be much greater, and then it's easier to study the relationship. So, taking 52 population samples from 32 countries, the INTERSALT study very clearly showed that as salt consumption rose, particularly to medium to high levels, the systolic blood pressure rose, and so did the diastolic blood pressure. But very interestingly, in low salt consuming populations, the systolic blood pressure did not rise with age between 20 to 59 years. That means the rise of blood pressure with age is not necessarily a natural and inevitable phenomenon. It can be controlled by the kind of diet you consume. The second lesson that came from INTERSALT was that sodium is important in terms of salt consumption, but potassium counteracts the effect of sodium. Therefore, taking a fair amount of potassium through natural foods like fruit and vegetables can reduce the adverse impact of salt consumption on blood pressure. So this gives us a very valuable insight into the kind of diets we should consume. The INTERHEART study showed very clearly that 9 major risk factors were responsible for more than 90% of the attributable risk across populations in the world for the first heart attack. Now, you could always say that populations will differ by ethnicity, they are likely to be very different because of genetic factors, but what it showed was much of the risk can be explained by some common factors which are mostly related to lifestyle, and these are not widely different across populations, they are very common. The mix among those 9 could vary in populations, but overall the 9 remain fairly common. So which means that the knowledge that we are getting from certain populations in terms of what works, in terms of reducing the risk, is applicable to other populations. You don't have to wait to do big studies of your own. You could actually gain from the knowledge from other populations, and these interventions can actually modify risk factors with substantial health benefits. So the idea of doing large multi-population studies is to get a better grip on risk association and also to get an idea of what is likely to reduce the risk across the populations.
So what are your views about the recent issue related to stunt prices in India, and what other policies can be implemented to control these prices?
I believe that all drugs and devices must be available at affordable prices if we are to benefit the largest number of people who need them. Quite often, we produce technologies at very high prices and make it inaccessible, or they impose huge healthcare costs on individual pockets and government budgets, or even social insurance programs. So the big question here is, are some of the high-priced stents really producing marked health benefits as compared to other stents? At the moment, the evidence suggests that the very high-priced stents offer very minimal extra advantage in terms of major cardiovascular events as compared to other available stents. So unless there is a huge difference, we should not really encourage the use of high-priced technologies just because they're available and are fancy. Just to tell you a similar story regarding the clot dissolving medicine, streptokinase and tissue plasminogen activator. Both are effective in dissolving the clots and saving heart muscle in the case of a heart attack. But streptokinase is much cheaper than tissue plasminogen activator. Comparative trials showed that tissue plasminogen activator offers a little more advantage compared to streptokinase, but when you look at the number of people you can save in a population by using the cheaper drug, the benefits are far higher for streptokinase. So similarly in stents too, the same logic must apply. If there are clear-cut, large-scale benefits that are demonstrable, then certainly the new technology, which is higher priced, can be adopted. Otherwise, we should stick to the more affordable and more widely applicable technologies.
Dr. Reddy, you are the President of Public Health Foundation of India. So can you please enlighten us about some of the recent initiatives by the PHFI?
Well, the Public Health Foundation of India has now established 5 institutes of public health, the Indian Institutes of Public Health in Delhi, Gandhinagar, Hyderabad, Bhubaneswar, and the 5th one is developing in Shillong. We also have a center operating in Bangalore. We are actually engaged in broadband, multidisciplinary education, research and training, which will translate into multi-sectoral applications to move different elements of the health system in the right direction, but also align policies and programs in other sectors to public health goals. We have actually now developed a very large-scale program of engagement with states and the central government to provide technical support as well for health system strengthening. We are the technical support unit for the HIV/AIDS prevention program of the central government as well as the routine immunization program of the government, central government. We are working with several states for not only providing training to their health professionals who are already serving in the government services, but also trying to configure how health systems can be reconfigured, how public health cadres can be created, how district models for universal health coverage can be designed and evaluated as pilot programs. So in a sense, we are actually trying to build much greater capacity within the health systems of this country to address some of the huge public health challenges that we have. I believe public health is not just about water and sanitation or prevention and promotion. They're very important, but creating the architecture of a good health system which can also deliver appropriate, affordable and accessible health care at primary and other levels, secondary and tertiary levels, is also an important function of public health. Designing the health system is an important element. Delivering the individual care may be the duty of a clinician, but designing the system to perform better, both in terms of outreach and effectiveness, is the function of public health, and that's what we're doing.
So what are your views on the current medical curriculum on public health and community medicine?
I believe in many of the colleges where it's being taught, it is not sufficiently multidisciplinary. You do not have enough epidemiology, you do not have enough social and behavioral sciences, you do not have health economics, for example, you do not have health management, you do not have health communication. Many of these areas are not there. We should actually bring in all of those disciplines into public health education. Secondly, the health system engagement is limited, and leave aside engagement with other sectors. So what we need is to transform public health education whether in a medical college or in a dental college or in a public health training institution, into a multidisciplinary but also health system connected education.
So, what are your views on digitization and its role in generating awareness among general population about public health?
Absolutely. I think we are in an era where knowledge has to be disseminated very fast. The general public and the community needs to be empowered with information so that they can protect, promote and preserve their health. They should become partners in ensuring that even their health care is appropriate. So it is absolutely important to provide that information. We can no longer depend upon a paternalistic pattern of healthcare which is doctor-centric. We need community and patient and family empowerment, and the digital transfer of information is highly empowering. It makes people partners in the overall management, whether it's prevention or whether it's treatment of a disease. And currently, I think we should make all the tools available to us, the e-health, m-health, the entire social media, in order to provide that information in a timely manner to people so that they can actually respond with the right kind of actions, whether it is alteration of individual risk behaviors like giving up smoking or changing diets, or in terms of group behavior like ensuring that they're not polluting the atmosphere with smoke in public places, or are encouraging everybody in the community to keep a clean and safe environment, or health-seeking behavior so that there are more institutional deliveries, there is a better rate of immunization and so on. We need to ensure that this information is actively helping people to become more engaged citizens in terms of health.
So, since DocPlex is an online professional community of doctors, so what is your key message to our community of doctors?
Well, I think doctors are absolutely critical players in supporting health of a population. Even if a doctor sees himself or herself as working in a healthcare facility or a clinic or a hospital, they are important agents of educating the community and empowering the community with information. So we should see public health and clinical medicine not as separate compartments, but as a continuum of care which starts with health promotion but ends with rehabilitation. And there doctors should play a role. And doctors are important agents of change because they command respect in society. If a doctor explains to the community why tobacco consumption is bad or why physical activity is good, that carries conviction to the community. If the doctor also says, do not consume antibiotics at random, do not buy antibiotics off the counter and take as you please, or if antibiotics are prescribed, don't stop after 2 days because that's going to cause antimicrobial resistance. A lot of bugs will become resistant and then you will not be able to combat them. Then that's the kind of messaging and education that the community must receive from the doctor.
Thank you so much, Dr. Reddy, for this interview. Thank you.
Thank you.
To stay updated on our latest scale videos and interviews, please follow us on Twitter, like us on our Facebook page, and subscribe to our YouTube channel. Happy DocPlexing!